today, so this will be great. We can do a lot of kind of small group talking. This will be an interesting topic because I feel like in the point of care ultrasound world, in the advanced emergency ultrasound world, I feel like we've really been leading the charge in terms of how to implement a quality assurance program, how to implement our middleware into our processes, how we're credentialing different physicians and other providers like APPs in terms of point of care ultrasound. So I think the point of today that I really want to discuss, is how to QA, essentially. How should we standardize this for regional anesthesia? So for those of y'all that don't know me, I'm Jonathan Brewer. I'm one of the ultrasound faculty at Vanderbilt University Medical Center in Nashville, Tennessee. I did my fellowship there last year, and I've been a blockhead now for about a year or so. So it's been a great experience. And for any fellows on the call, highly recommend y'all stay as blockheads. It's a great group to be a part of. But we're gonna go ahead and get started, guys. So kind of moving forward, this is a really broad topic. Now, when you think of QA, we do have some national standards, but each institution has kind of created its own protocols and methods for QA. So, again, like I would argue that emergency medicine is really leading the pack on this. But I think in terms of regional anesthesia, we have a lot of our acute pain service physicians, and I've been kind of polling some of them to see what they've been doing versus showing my background. Dan, what's it doing now?
I'm seeing the Grand Canyon. Oh, there we go. Requirements.
Okay, perfect. That's part of our slide.
It's still the Grand Canyon.
Okay, perfect. So, all right, how about now?
Great.
Good. Okay. So, I really wanted to show that this is more for any fellows that are on right now, but the American College of Radiology and ACEP have defined what needs to be documented so an ultrasound can be billed. So this is 4 different requirements. And so CMS, the Center for Medicare and Medicaid Services, they actually have guidelines that require these four requirements to be documented. Now, QA takes a peer review process from that, right? So this is kind of a 10,000-foot overview where a POCUS expert or a fellowship-trained physician takes this trainee's ultrasound image and then provides feedback. So, we do this for competency as one large measure, but also in terms of portfolio development, learners can take these images and start to demonstrate improved POCUS skills, right? So it's about competency, it's about billing, it's about creating a safe standard for your institution. Now, we all know there are many different middleware companies, and a lot of different institutions use a lot of different middleware companies. So here at Vanderbilt, I'll show you we use QPath-E by Telexi. So we've actually created our own kind of note template here. But the question I want to kind of pose a little bit later on is, you can see here in our QA, so we have these requirements are, did you require all necessary images? Are they technically sufficient, right? And that's one thing to talk about. What is technically sufficient, right? So if it's technically limited study, you see that in the exam results, we actually don't count that towards their overall numbers. But the question is going to be, what constitutes that, right? Is it a bad image? Is it a failed block? Like what? We're going to talk about that a little bit later. And then, of course, the accuracy of your interpretation. And then we always talk about appropriate gain, appropriate image depth, things like that as well. So I took a really in-depth look at the regional anesthesia literature to see what they're doing. And I also polled some of my friends here at Vanderbilt and other institutions from the acute pain services to see what they're doing for quality assurance. To date, there's actually no national valid and feasible set of quality indicators in regional anesthesia that's available for monitoring their patient outcomes and the quality of their perioperative care. They look at certain factors that I'll talk about here. The most regional anesthesiologists, I don't know, Dan, at your institution, it's a little bit different, but like here at Vanderbilt, they will save an image to a central server, but very few institutions seem to be doing QA to the extent that emergency medicine is doing, where other regional anesthesiologists are going to QA those blocks of other faculty, of fellows, to determine their competency, determine whether or not they should count their overall numbers, and also in terms of standard of care and safety. So there was a study that the NHS in the UK published in 2020. They took best practices for regional anesthesia, and they analyze what should become our standard in the UK for quality and safety of peripheral blocks. Okay, now this was not neuraxial blocks, it was peripheral blocks, but there was no mention of a specific QA process. They focused a lot on review of any sort of complications from LAST toxicity, from other peripheral neuropathies. They looked at safety of these blocks. but there was no mention of where another regional anesthesiologist would actually analyze the technique and image review afterwards. There was actually a systematic review in the anesthesia literature that looked at different quality metrics, and this is from that paper. So as you can see here, outcome, safety, efficacy, these are all large metrics that APS or acute pain service is focusing on. But again, for image review, it's not even on here. So you can see that there's not a defined standard right now. So, I think we have this unique opportunity to kind of lead the mantle on this. Now, ACEP actually came out in 2015 and created a procedural guide for reporting guidelines. In 2018, they created the standard reporting guidelines. There's a lot of amazing people that were a part of this. But in 2015, they came out and they said that in order to standardize, they actually had regional anesthesia on there, or nerve blocks. They said you needed 4 requirements. There was adequacy of individual views, accuracy of the interpretation of that individual view, a gold standard interpretation based on images, but that was not defined as to what a gold standard is, and then overall adequacy of examination, right? And this is actually this is on the 2018 guideline, as you can see here, where they took a 1 through 5 grading scale and said, this is how we would recommend a quality assurance for emergency ultrasound exams. This was actually off of the FAST exam that I took this scale right here. There's actually not a defined QA grading scale for regional anesthesia that ACEP has published themselves. So, my question today that I really want to pose first off, and this is where I really want to open this up to discussion for everyone, is kind of what markers should we be tracking? And what I mean by that is, how do we determine that images are sufficient? Should all nerve blocks undergo QA? And in that setting, right, a lot of us work in academic centers. Some of us may work even in the community. How do you make that a reality, right? So like in community metrics, there was actually a paper that looked at the SMART metrics. They call it specific, measurable, actionable, realistic, and timely. And their goal was only to have even 50% of their ED physicians archiving scans, and then 80% being billed. So that is, those are community metrics right there. So how do you make this a reality? And, how do we determine these images are sufficient? So I just want to open that up. I got a couple questions here, but I'd love to get everyone's thoughts, fellows, faculty, kind of going through.
So I guess one thing I want to point out, my name's Leland, by the way. I think I've met a minority of you guys, faculty at Brown. Not all fascia iliaca, for example, or blocks that we pretty much only use ultrasound are always done with ultrasound, especially outside the US. It can be done. And then there's some blocks even in the US that we do pretty much without ultrasound. And so I guess the first caveat is that when ultrasound is used, and that's just would be more applicable if you're trying to create a national standard, I guess. But then that raises the question, well, those aren't going to be QA'd. But when ultrasound is used, I agree we probably should be QAing it, but it would just recognize the fact that not all of these blocks always use ultrasound. Which is probably why it hasn't come up in anesthesia also, because at some point they showed with ultrasound you can use last anesthetic and that it's better, but they classically were not doing it. And I think maybe in a lot of places in Europe, they have a fatter needle. They just feel 2 pops and they go, for example.
Mm-hmm. Yeah, and a lot of places, that aren't doing ultrasound guided, they're still doing STEM-based techniques as well.
Yeah.
So, if we're ever doing, blocks like that, should we be doing, based off of efficacy? Or there's an interesting kind of discussion here as to, when you're doing non-ultrasound guided versus ultrasound guided. I think the conversation here, I completely agree with you, Leland, but I'm wondering, like, for ultrasound guided, if we should just make that, 100% of blocks or 50% of blocks, like, kind of what everyone's thoughts are on that.
So, like in standard QA, my understanding from at least the 2018 or 2016 guidelines, I haven't read through the 2023 update, but my understanding is that you have to do at least 20%, right? That's the minimum. Hopefully everyone's aiming for 100, but the minimum is 20%. So at least 20% of all blocks should be reviewed as part of that same kind of standardization. The other thing was, I saw in your QA that your questions were those 4 just standard questions, yes, no, whereas the FAST that you quoted with the 1 through 5 rating, false positive, false negative, all that sort of stuff, those do not appear to be the same. Mm-hmm. So my preference would be to just have a standard QA process, use the ASAP guidelines, the 1 through 5 rating, the gold standard, blah blah blah, all that, those standardized questions we're all used to. And I don't love that nerve blocks would be different from that process, because we do the same thing for IVs as a procedure, central lines and so on and so forth. So they get QA'd the same way as all our diagnostic scans. Why are we saying nerve blocks should be special? I would be I think it would be reasonable to have a separate process where you would look at the chart and just make sure that the outcomes were okay after the event, to look for things like, peripheral nerve injury, last events, some of those other critical complications that we're all afraid of. But that's, I feel like, is outside of the ultrasound image and the documentation of that image. That I feel like those are two separate things. How does everyone feel about that?
I will say I feel like one of the differences with us in anesthesia and why sometimes they don't like us doing it is something you just brought up is, for example, when we cause peripheral nerve injury, they will keep following up with them Q1 month or 2 months until it goes away, and then eventually you're referred to neurology if it still hasn't after a year, although 99% go away after a year. And the fact we don't do that, they do not like. And so I think you brought up the point, but that brings up a whole nother can of worms. There's no way we can do that.
Yeah, I think y'all bring some great points here. And so I think in terms of, QA, it may just be a good idea for us right here to be focusing on like the ultrasound image itself. Now I've talked to a couple individuals that, find it difficult to even trying to save images during blocks and stuff, but I find that a lot of individuals are at least able to save an image of their needle within the realm of the perineural block or the fascial plane block. So I feel like that, at least should be our standard. I don't know if anyone has any other thoughts there. Looks like Dan agrees. So, all right, cool. So another question I wanted to pose too, based off of that, is who should be QA, right? And so, does it what is going to be our standard minimum here? So is it going to be someone who is a block champion at an institution, they've had needle training, they've gone to an ISORA course, an ASRA course? Is it someone who's fellowship trained plus regional anesthesia training? So this is something I just want to open up to everyone as well. And what should that training entail? Oh, sorry.
I mean, as a basic starting point, not everyone who's ultrasound fellowship trained has done all of these, and you probably should have done it if you're going to QA it. And then you can discuss numbers after that, but that's like a basic minimum, I feel like. But then, we don't do that now or have that in place now.
What about academic centers who, have some fellowship trained physicians, but as you said, haven't had extensive regional anesthesia, but you have someone who maybe not ultrasound trained, but does have regional anesthesia experience? Should they be allowed to QA these blocks? Because I also think about, if you're trying to create a standard, I also think about community groups as well, that may have, like, I know one community hospital that right now they're old, it's part of their hip fracture protocol that every hip fracture gets a fascial iliac block, but they don't have any ultrasound trained individuals.
I think the only limitation you may come in that model is that if they don't have ultrasound trained people, like, do they even have an archiving system? Are they using it at that kind of level to be able to support that stuff? If people have those pieces in place, it would be very reasonable to say, if you have the competency and you have numbers to be able to support QA, presumably if somebody would want to be in that role outside of an ultrasound person.
I also believe that the standard in emergency medicine for being credentialed to perform any procedures, that you have to have performed at least 10 of them. For when we credential people for ultrasound peripheral IVs, 10 is the number. Intubations, I think it was like 30 or something like that. But whatever the standard is for performing that procedure within emergency medicine, I think whether you're ultrasound trained or not, if you've met that baseline standard and you went through a residency program that had that training, that you're done. You're good.
So do we feel that 10 blocks plus, again, like you said, Dan, like a residency training with that, should that be adequate then?
I mean, it's not a perfect world, but I think you have to draw the line somewhere, and you have to make it both accessible but also safe. And so previous procedures have drawn the line at 10. I believe that to be reasonable.
I think 10 is reasonable.
Yeah, I agree.
Yeah, I'll say so. My name's Matt Milk. I'm actually Peds EM. Sort of Arun ran into him and got hooked up on this for these meetings. So like our QA side, and it's interesting because we've been having some parallel discussions from like a larger hospital-wide focused expansion and like who's going to QA different departments and what are the numbers. And like our fellows, we do like 500 scans before they do QA within the general imaging. And the procedural side is often this like historic, like see one, do one, teach one, and you're signed off and you go. Our IV protocol for our nursing is 10 successful, but they have to do 30 to be able to proctor, and so should it be more to be like a higher level sign off person than it is to be the educator, or to like enough to do it, but more to sort of teach and judge someone else. Again, I think you're right, strike the right balance of like, you have to be accessible, but you also want to ensure quality. And it's a tricky balance of where you're going to be for that.
Yeah, it is a little tricky because I try to think of something that can be more generalizable to all institutions too, versus something that's going to be only specific to a place that's got 7 ultrasound faculty. And so I agree. I think someone who's had 10 blocks, the question is going to be, should they, what kind of blocks have they had, right? Is it 10 fascia iliaca blocks, but then are they allowed to QA interscaling blocks now versus just 10 peripheral blocks in general?
I think that goes back to the feasibility question. Honestly, if you require 10 of all of these, some of these are just never going to get done in our specialty.
Yeah, and I think we also have to just start somewhere. Because in regional in anesthesia, it's 40. It's
Yeah,
not much different.
Yeah, exactly. So interesting thoughts as to kind of how should we standardize this, and maybe in our next ASAP ultrasound guidelines, then we can come up with a standard. That way, every institution can start a quality assurance program for this. And then finally, one thing I wanted to talk about too, again, is the difficulties and the barriers. And we've kind of touched on these a little bit, right? So in terms of software, right? So middleware software, it's expensive. Faculty time, the extra work to log images, and again, what are we going to constitute as a limited study, as a technically limited study? What is we've had the 2015 procedural guidelines. They discuss the gold standard. What is our gold standard for a block going to be? Is it what anesthesia has determined with their ultrasound images? Is it something that we establish? I'm curious to hear y'all's thoughts on that. Yeah, when it comes to gold standards, I personally think, in terms of someone who can be a block champion who's had regional anesthesia experience and is leading the charge on the QA, there's a lot of great resources out there. I mean, as y'all know, NYSORA's got some amazing resources in terms of teaching. Their app is really good. Their courses are really good. I'm wondering if that potentially those images should be kind of our gold standards that we're comparing to, but it's hard to be able to say what's a limited study. If we're trying to do a procedure and save an image, what constitutes that limited study? I know what we do with IVs, but I'd be curious with nerve blocks.
So just a quick question, and Kat, I don't know if you're actually on the call, if you're available. I believe you had the actual CPT codes for a lot of these blocks, And do you have any opinions on what kind of allows you to bill for that CPT code? I feel like that's kind of the core of this question.
Okay, yeah, so you just need one image, quite frankly. You don't need a video. You don't need to show the hydrodissection plane. If you can show for example, with a serratus, if you can show needle in plane with an anechoic stripe, you're done. That's all you need. So from a billing standpoint, the requirements are actually quite simple. It's what you write in your procedure note that will limit what you can actually capture on your billing. So you can bill for the procedure. That doesn't mean that the insurance company is going to be amenable to giving you money for any of this. They're going to want to, and this is a conversation with your coders, but they're going to want to know needle direction and cranial to caudal and how much anesthetic used, and if they're in a cardiac monitor and what positioning they were in, all this nonsense that makes sense, but it doesn't make sense to coders. So you need to know actually the most common omission that we see is whether it was the right side or left side that was done. And so it's silly things like that. But in terms of image capture, the requirements are actually quite little.
Okay, so I'm wondering, as a side issue, if we have a billing episode that our worksheets in QPath or whatever software we're using should include those things that the insurance company is asking for, even though they're not necessary for billing on a CMS level. That's an interesting separate topic.
Oh
To
yeah.
follow that up, I feel like for research purposes, I wish more places would have the pain scores before and after, although that requires the provider to go reassess. But having all that data would be is just really cool, not for billing.
And here's a shout out for the nerve block registry project that we're all becoming a part of as well. And I think that'll provide some really good data. But again, Kat's completely right? You only need one image for the billing purposes. And so in terms of competency, I feel like it's difficult if you just have one image of planet to say, that was a technically limited study. We shouldn't count that towards your competency. But if you're getting an efficacious block, but you also get an image that's within the realm of the nerve or within the fascial plane, then it probably should count towards your numbers, your competency. I think we have something in the chat too. Oh. Anyone have any other thoughts? Any difficulties with establishing a standard for this as we move forward? Because the other question is going to be right now, generally at most institutions, the people that are doing QA are ultrasound fellowship trained individuals. And so, if we're talking about in the future saying, 10 blocks, you can be able to do QA for your group. Is that something that we're going to make standard? I know we have to start somewhere for sure, but is that something we're going to make standard, or do we still say, you should really have someone who's fellowship trained? But not all fellowships get extensive regional anesthesia.
I think this is also going to partially depend on our progression through the not the RUC committee, but the ACGME accreditation requirements, because there's a push from some of our colleagues that 10 regional blocks be added to the necessary procedures for graduation from the ACGME side, as well as in order to have an ER residence, you must have at least one ultrasound trained faculty member. Those, to my knowledge, have not yet been put in stone. They were proposed last year, and I think 2 years ago, and last time I checked on it was not in stone and was still under review. But I think once that stuff actually gets nailed down, you'll have a much better standard of resident coming through, and then we can always revisit these things after those residents start to become the primary population.
Mm-hmm.
I think it probably makes more sense to have like a competency driven approach as opposed to fellowship trained, because I think having the broader appeal, and when we were working on developing different models for the TE guidelines and trying to get TE out there in the hands of people, it was way easier to use a competency model than saying someone needed a specific level of training, because we're not going to allow people to have access, or not everyone's going to have access to it. And I think we're all kind of in agreement that people want we want to get blocks out there and get people to be doing it in a standardized and more robust way.
Exactly. And I've actually been Dan, to your point, I've actually been working with ACGME on that the last few months. And it's something that we are pushing. They actually did a large study this year where they analyzed every emergency medicine residency and kind of what their core ultrasound requirements are right now. And as you guys know, there's a very large discrepancy between residency programs right now. So that's my hope, is that, you know, we will move towards 10 nerve blocks throughout their residency. And hopefully that's, you know, that doesn't become a very loose requirement as in like 10 digital blocks, you know, 10 actual like peripheral nerve blocks for residency requirements, and then with an ultrasound faculty. So that would be great. I think that'd be a great starting point, and that would really help to kind of move this forward. Unfortunately, you know, based off their timeline, I don't think these requirements are going to come out for another probably 2 years or so. But they are presenting at Cord this year, so hopefully we'll see some good data then. So, anyone have any other final thoughts on this? I know it's not a very broad topic, but it's something that I think is important for all of us. You know, as we move forward, as we start to kind of really, you know, make an effort to push this forward and make this standard, our mainstream in emergency medicine and advanced emergency ultrasound.
Totally agree. While everyone's still on the call, I had a quick question for Dr. Jaffrey, or whoever is in that team over there. When you said the TEE was competency based, was there a competency assessment? Did you have to prove you already had a number of like sim events, or you did a number of real TEEs? What was the standard and how was that quantified?
It really came from everyone's experience who were developing programs and going to different places. And so technically it's like an expert opinion that we came up with for it, but it was 10. 10 was the number that we said, and 10 would be what it required to be able to, you know, proceed and move forward with it. And local, like we recognize that there's different local groups that they're going to do different things, or they may have more stringent requirements, but we figured if ACEP created a standard of 10, that would be attainable for people, and to be able to kind of get at least the program started.
Is it 10 plus simulated cases, or just the 10 live?
We left it at 10, intentionally ambiguous, that at least you should have 5 live and 5 scan, or five simulations are okay. The initial guidelines had only 10 involved, I think total, so it could be like 10 simulations, 10 simulated or live, but we said we recommend at least 5.
It's kind of similar to what we did with our peripheral IV program for the nursing staff, is they get to do 5, but they have to be watched when they're doing 5 IVs. But then after that, they can do IVs on their own. But then after a full 10, do they get the credentialing certificate? But they do like 50 or 60 on our various simulation models before they're allowed to do it on people. So I'm wondering if that's a sort of a similar mindset there.
Well, thank you guys. That was a great discussion. I really appreciate everyone participating in that. So it'll be interesting to kind of see, especially as we move forward with ACGME, as we come out with, you know, new standards. You know, we have TE credentialing guidelines coming out, hopefully. So that's I'm looking forward to seeing what we come up with.
Thanks for getting together.
Thank you very much for running this.
Yeah, absolutely. All right. I guess you all have a wonderful day. Good seeing y'all.
Have a good one.
Nice meeting you guys.